Prevention Center in Spokane, Washington. She is also an adjunct professor at Texas Tech School of Nursing. An international speaker on cardiovascular disease prevention, she is the co-founder and instructor of the Bale Doneen method course for the prevention of heart attack, stroke, and diabetes, as well as the chair of the Pacific Northwest Prevention Cardiovascular Nurses Association. Amy cannot attend this evening. She's traveling. We still have a very powerful team in the persons of Doctors Bale and Neighbors. Now, before we begin our presentation and hand it over to Dr. Bale and Neighbors, a little bit of housekeeping reminders. We will be polling the audience at various points through the presentation to gain a insight into kind of where the audience is on certain topics. The entire presentation is scheduled to last approximately 1 hour. You are, as attendees, are on mute, but we encourage you to submit your questions through the question box, which you should see on your screen. And as we approach the conclusion, or perhaps during the presentation where appropriate, we will share these questions with Doctors Bale and Neighbors. And that's pretty much it. I'm just very excited about the opportunity to share this sneak peek with everyone. I can't wait to get there. For those of you who may have attended a preceptorship or other presentations by Bale and Doneen or Neighbors, they seem to be everywhere these days. They've been on both scientific sessions for the American Academy for Oral Systemic Health meetings. And this is going to also offer the business side, not just the clinical side, but as I said, the means to actually incorporate and make these protocols your own so that you can make sure they're not a well-kept secret in your community and thereby grow your practice. So with that, I want to hand it over to Doctors Bale and Neighbors, and thank you very much, gentlemen, for joining us this evening.
Yeah, thank you, Danny. Yeah, Tom, do you want to say a few words before we get going?
Happy to, and thank you, Dr. Bale, for being on this webinar tonight, and I especially want to thank Danny and his team and AIM Marketing for the wonderful opportunity that we have to bring our message to this group. And most importantly, I want to thank the listeners for taking the time out of your day to listen to this webinar. We look forward to providing information this evening, and we really look forward to meeting you in Las Vegas. You obviously have an interest in this topic, and we really are looking forward to November the 2nd and to meeting each one of you and to hopefully answer your questions about how we as dentists and physicians and nurse practitioners can work together to prevent diabetes, heart attacks, and stroke. So with that, I'll turn it back over to Dr. Bale.
Okay, well, thank you, Dr. Neighbors. Yeah, I am sorry my colleague, Amy Doneen, isn't able to join us tonight. I'll do my best to make up for her absence, and those of you who do decide to come to our course in Vegas, you'll have an extra treat of being able to hear Amy live at that program. But I do want to thank Mr. Bob Rowe and AIM Marketing for allowing us to be part of their Practice Perfection educational series. We consider this a wonderful opportunity. We love talking about preventing heart attacks and strokes and diabetes, and consider this an excellent opportunity for those of you who have joined in tonight. Certainly appreciate your interest in this subject. It is extremely important, and you can play a vital role in making a huge dent in the morbidity and mortality with cardiovascular disease in this country. So thank you for joining in. The outline that we're going to cover today, the first thing will just be a general overview of the incidence of periodontal disease and cardiovascular disease and what some of the top cardiology and periodontal societies have had to say about the connection between the two. Then we'll cover some evidence about how periodontal disease is associated with cardiovascular risk factors, a development of arterial disease related to the risk of actually having a heart attack or stroke, and then evidence that treatment can impact those cardiovascular risk factors. Then we'll address the recent American Heart Association paper, and we'll mention an online course that we have that's worth 2 continuing education hours, and then we'll finish with just general information about our course coming up November 2nd in Las Vegas. In terms of the overall incidence of periodontal disease, we have excellent evidence to go with that was published in August, where they looked at an extensive review through NHANES, and for the first time they examined all of the teeth in 6 ways each tooth was examined other than the 3rd molars, and they examined for pocket depths and attachment loss. Prior to this, there was never that degree of an extensive evaluation. And what they found hopefully doesn't shock you, although I guarantee it shocked a lot of the public, when they reported 50% of Americans 30 years of age or older have periodontal disease, and if you're 65 or older, there's a 70% chance you have periodontal disease. That certainly makes it one of the most prevalent chronic diseases in this country, and a lot of those patients do not realize they have periodontal disease. And then I'm going to let Dr. Neighbors talk a little bit about one disturbing lack of information from this recent review, and that is people under the age of 30 were not evaluated. So Dr. Neighbors, you want to make a few comments about that?
Thank you, Dr. Bale. This is really a landmark study, as those of us who are on this call recognize for the first time, as Dr. Bale stated. We have a full mouth probe chart of those that are greater than age 30, and the statistics are quite large. Looking at numbers, 50% of Americans over 30 represent about 68 million Americans with periodontal disease. And then when we add the 20% that are greater than age of 65, we see that, you know, somewhere between maybe 80 and 100 million Americans have some form of periodontal disease. My experience in working in a molecular laboratory and actually viewing clinical laboratory reports is that clinical signs of periodontal disease occur long before bone loss occurs. And unfortunately, NHANES, as well as the periodontal community, are using well outdated mechanisms for measuring periodontal disease. We have to wait for, as Dr. Bale would say, the event to occur, the event meaning bone loss. And when we look at clinical laboratory reports of individuals that are less than 30 years old, not only do we find periodontal disease in the 20s, we're even finding risk for periodontal disease as young as 7 years old. That's quite unusual, but we have clearly seen individuals 7 years old, 12 years old, and in their teens that not only have periodontal disease but may be at risk. And the reason that this is so important is if we are going to tie in periodontal disease to vascular diseases, which we are, and that's what the studies are requiring us to do, we also have to look at cardiovascular diseases earlier, as Dr. Bale is doing, and using risk assessment models that include younger populations, because these diseases do occur earlier than 30 years in many individuals. So I think this is a missing component. I know that it's a missing component, and hopefully in future NHANES reviews they will include other forms of recognizing risk or other forms of recognizing disease. Certainly in our practices, we don't have to wait till age 30 before we start looking at individuals more closely.
That's a really valid point, Dr. Neighbors. And as I know a little bit from already attending some of the Bale and Doneen programs. Unfortunately, cardiologists are waiting for the event, which in that case is, often too late for the patient. And I guess it's similar on the oral health side when you're waiting for bone loss to be the indication. That's tragically too late. But let's take a moment to ask our first poll question, because we've already introduced basically the epidemic nature of periodontal disease, and I'm curious to know how many of the attendees believe that periodontal disease is actually an independent risk factor for heart disease. So if all of you would just vote, just click true or false. We'll keep the poll open for 30 seconds or so, and let's see what the results are. I have a feeling we're going to know, because this is a savvy group we're speaking to. Okay, why don't we go ahead and close the poll and see what the results are. Okay. And as we suspected, 85% believe it's true and 15% false. So let's continue with the presentation, and we'll see if we can convince 100%.
Okay, before I address this slide in particular, I would just like to say, albeit the recent NHANES study looking at periodontal disease is far from perfect and doesn't address the subclinical periodontal disease, it's still rather stunning to realize at least half of adults 30 years of age and older have periodontal disease. It's a huge incidence, and we know it's even greater than that because of what Dr. Neighbors had to say. In terms of cardiovascular disease, today already a couple of thousand people have died from cardiovascular disease. Somebody dies from that about every 40 seconds. And about 150,000 Americans will perish before the age of 65 from cardiovascular disease, and that robs them at least 13 years of expected lifespan now, which is a huge loss. So cardiovascular disease is extremely prevalent as well. And a study that was published in July looked at an adult's risk of either having a cardiovascular event or dying from cardiovascular disease versus the risk of dying from a non-cardiovascular reason. And what they found was that you're 2 to 3 times more likely as an adult to either have a cardiovascular event or die from one than you are to die from a non-cardiovascular disease. That's huge and frightening, and it's an unacceptable incidence of cardiovascular risk in this country. And as we're going to talk about tonight, there is evidence that periodontal disease is independently associated with cardiovascular risk, and that means the dental community can play a very instrumental role in changing this statistic. And those of you on the call tonight, I applaud you for being here and your interest in this subject. Thank you. We do have large organizations from the cardiology field and the periodontal field who have recognized this association. 3 years ago, there was a joint statement from the Journals of American Journal of Cardiology and the Journal of Periodontology stating that there is a confirmed connection between cardiovascular disease and periodontal disease. They went into a lot of the biology of how this occurs, and they actually provided some recommendations for treating patients. Then a year later, the European Society of Cardiology stated that oral health and periodontal health is a very important component for preventing cardiovascular disease.
Well, you know, it strikes. I'm sorry, Doctor.
Go ahead.
Go right ahead.
No, go ahead, Danny.
I was just struck by this, as I imagine a lot of our attendees are, that given all this overwhelming evidence, and some of it is not all that recent, that, as we know, a number of media outlets have stated, or at least inferred, that there's no relationship between periodontal disease and heart disease. And I'm wondering where that came from and how you might respond, either of you gentlemen, to those assertions.
Yeah, that was an unfortunate twist in the American Heart Association publication, which actually clearly stated that periodontal disease is an independent association, has an independent association with cardiovascular disease, and it's extremely hard to show an independent association. What that means is you've adjusted for everything you can think of to adjust for that is known to be associated with cardiovascular disease. So you adjust for blood pressure, for BMI, for the cholesterol, etc. And after making all of those adjustments, you still find whatever you're looking at, and in this case it's periodontal disease, was still associated with the risk of cardiovascular disease. That's huge. And it was level A evidence, which is extremely hard to achieve. JAMA, our Journal of American Medical Association, published several years ago that our guidelines should be viewed with great caution because less than 20% of the guidelines are based on level A evidence. A lot of them are based on evidence that isn't that strong, or simply the opinion of the experts on the panel establishing the guideline. Level A evidence is very hard to achieve. So that was a huge statement. But in that paper, they went on to address causality, and we're going to talk about that towards the end of this presentation. That's extremely hard to prove with anything, that it's an actual cause of disease. So that's what the media ran with, and the headlines got all twisted, and this very powerful statement of level A evidence of an independent association got blurred in the media.
Buried.
It's a shame.
Yeah. How unfortunate.
May I add one comment there, and that is that all of us have to get this right. Physicians, nurse practitioners, dentists, dental hygienists, periodontists, oral surgeons, we have to get this right. And it is unfortunate that there is confusion that was created as a result of the AHA comments. The body of the article was very strong. It's unfortunate, however, that the concluding remarks created the confusion. Having said that, two of the lead authors of the AHA article in April came back and revised their statements in regards to the concluding statements in the July issue of the Journal of American Dental Association, and they clearly are backtracking on some of the lesser statements that they made, because we don't want to be set back. In other words, the medical profession, the dental profession, we're all medical professionals when we're dealing with this issue. And we certainly don't want to go backwards. And so one of the things that we will do on November 2nd is we will guarantee each one of you, you'll be prepared to answer these questions. Your patients are asking those questions today, and you will be very prepared when you come back from that meeting, both in your own confidence and your staff's confidence, but also as you address that with your patients.
Yeah. And prior to our presentation, we were discussing that while it's an unfortunate kind of a twist that the media reported on, Controversy can at least encourage discussion and debate. And someone once said, well, many people say bad news travels faster than good. To the extent that people are made aware that there's a debate going on, I think, as you just said, we can turn that to our advantage as long as we're prepared to address it effectively.
Yes.
Yeah. Yes, but yeah, so it was an extremely powerful publication, and based on that level A evidence, my partner and I feel very strong when we state any program that claims to be involved with prevention of cardiovascular disease absolutely has to include the oral systemic component. With level A evidence, you have to do it. So it was an extremely powerful paper.
I might add, please, Dr. Bale, a comment here just from my recent observations. I've met Dr. Bale and Ms. Doneen about almost 3 years ago, and what I realized is that they wanted to know more about periodontal disease. They wanted to know the evidence, and they already knew an awful lot about this relationship. But having said that, they needed a way of measuring this relationship, and one thing that we will discuss at our November meeting is that they understand the importance of being able to measure risk, because it's the ability to control risk that ultimately culminates in our ability to control disease. And so when they see patients and they are trying to prevent heart attacks and strokes, which they are doing, they also include an oral examination, working with dentists that will work with them. That's an issue we will talk about as well. But they also will use relative tests, both that are serum-related, urine-related, and also salivary-related. And so they are on top of their game in bringing this not just by word, but actually looking at the evidence based on appropriate tests.
Yeah, that's an excellent point. And the medical providers that go through our 2-day course, after they leave our course, they're dying to find people in their community who are oral medicine specialists. And there are not near enough oral medicine specialists out there. And one of the focuses of our November 2nd course is to make any dental provider that attends that course should walk away feeling confident that they are an oral medicine specialist, and then the medical providers that go through a 2-day course are going to want to partner with you. And we need more in this country, oral medicine specialists. So again, thanks for being on the call. So with this level A evidence, you would think there is evidence that periodontal disease would be associated with some cardiovascular risk factors, certainly, and we do have such evidence.
Why don't we hold the audience on that, and before we give away the story, because I think now that we've established that there's an independent risk, it's an independent risk factor, let's see what our audience thinks about the question of whether periodontal bacteria can actually be a better predictor of vascular disease than the clinical signs of periodontal disease. And just take a few seconds to answer that question. I know there are studies that talk about C-reactive protein being a better predictor than cholesterol. That's after, I think, the cascade has occurred, because that's already systemic. But the periodontal bacteria as a better predictor of vascular disease than clinical signs. Let's close the polling and see what we think. Okay, so 92%. Believe that to be true. Wow. We've still got a couple of people that we need to talk to.
Yeah.
Go ahead, gentlemen. Thank you.
Yeah, that's great. one study that we're going to mention specifically tonight that deals with the cardiovascular risk factors indeed demonstrated that it's a concentration of certain bacteria that are associated with cardiovascular risk factor, and the risk factor we're talking about in this study is blood pressure. So they looked at 650 healthy folks who were 55 years of age or older, and they tested them all for concentrations of 4 bad periodontal pathogens of Porphyromonas, Gingivalis, Tenorella forsythia, and Treponema denticola, and Actinobacillus. And what they found was very interesting. Individuals who were in the highest tertile of burden for these bacteria had significantly higher blood pressure, the systolic being 9 millimeters of mercury higher, the diastolic 5 millimeters of mercury higher. It was very statistically significant. So the risk of harboring hypertension when you're in the highest tertile of burden for those bacteria was triple the risk. And they adjusted, as you can see at the bottom of the slide, for numerous other known risk factors. And
Dr. Bale, may I ask a question there for the audience to know? And I will just say that many of us have not looked at risk based on odds ratios or relative risk, and this may be somewhat new to us. But when you say that something creates an odds ratio risk that is 3 times greater, would you comment on that, how relative that is when you are managing patients that are at risk?
yes, well, obviously it means that if you are harboring high concentrations of these 4 bacteria, you're in the top tertile, you are 3 times more likely to have hypertension. Hypertension is the #1 risk factor for ischemic strokes. And what a lot of people don't realize is that even pre-hypertension, that's blood pressure from 120 to 140, is extremely dangerous. It was published in 2005 from the Framingham data that over a 10-year span of time, blood pressure in that pre-hypertensive range increases the risk of having a heart attack during a 10-year span of time, 3.5 times increased risk of heart attack. The Kaiser data, where they collected data for over 250,000 people and followed them for 20 years, found that the pre-hypertension increased the risk of going on to end-stage renal disease by 62% increased risk if you had the pre-hypertension. So it's not just hypertension. So if you have a patient who normally is going to have an excellent blood pressure like 115/75, what we're looking at with the highest tertile of these bacteria is taking, basically doubling their risk of dying from cardiovascular disease. So it's a huge risk. And what was interesting in this study is that they found it was not the clinical diagnosis of periodontal disease that was related to the blood pressure. It was the actual concentration of the bacteria, which really calls into question how should the dental community be defining periodontal disease. Again, if you're looking at bone loss and pocket depths, that's rather end-stage disease, and perhaps the definition should change and certainly at least include looking at the burden of certain pathogens that are known to drive cardiovascular risk, like the 4 we discussed in this study. There is lots of other evidence, and we'll be presenting some of that evidence at our course on November 2nd with other risk factors that we know periodontal disease is associated with, such as the lipids and change in blood sugar. And what we would argue probably the most important, the inflammation. We now published in the journal Lancet, 2 huge genetic studies that show inflammation is causal of our disease. Extremely difficult to prove causality with anything, but through this wonderful genetic work published in that excellent journal, they did show inflammation is causal of arterial disease, and we certainly have evidence periodontal disease can manifest itself systemically with arterial inflammation, and that causes arterial disease. I mean, it's a huge deal. And then there was an interesting study published a couple of years ago showing that toll-like receptor 4 appears to be a critical factor in the development of insulin resistance, which goes on to cause type 2 diabetes. And you're probably aware, of course, that those bad pathogens we talked about a minute ago, they cause increased lipopolysaccharides, which attached the toll-like receptor 4. And what they've discovered so far is it doesn't matter what stimulates the toll-like receptor, whether it's oxidized LDL, free fatty acids, lipopolysaccharides, it doesn't make any difference. The chemical reaction that occurs after that toll-like receptor 4 is stimulated is the same. So we all know there's an association between periodontal disease and diabetes that could very well be linked through toll-like receptor 4 and the lipopolysaccharides, but we'll go into that in more detail.
Let's go ahead and share our third poll question, which is just, I think people are starting to get the rhythm of this test, so they're probably going to score consistently better. So this third and final poll question addresses this large longitudinal study which revealed that severe forms of periodontal disease increased risk of early death by a factor of 3.2 times owing to cardiorenal failure. And just take a moment to share with us if you think that's true or false. All right, let's go ahead and close the poll and see what we think. Ooh, 98%, 92%, 8% are not convinced. Mm-hmm. Let's share some information on that study that in fact did occur.
Okay, yeah, I think we have just a couple of slides to get through before we get to that, but first of all, you know, so we know periodontal disease is associated with certain cardiovascular risk factors. So is there evidence periodontal disease indeed is associated with development of cardiovascular disease? And there's lots of that evidence. We're just going to show one slide that demonstrates a few years ago the United States Prevention Services Task Force did a huge review of prospective studies with healthy subjects and demonstrated from that that periodontal disease again is independently associated with the development of coronary heart disease. And at our course in Vegas, we're going to talk about other studies, and one that's very intriguing where these pathogens that we mentioned before are actually found within the carotid plaque, the arterial disease in the carotid arteries. So getting on with evidence that periodontal disease is associated with events. So we've shown it's associated with risk factors, the development of arterial disease. So is it associated with actually having a heart attack or stroke? There's lots of that evidence. The one we're going to share tonight dealt with the Pima Indians, Native Americans, who have a very low incidence of smoking and alcohol use, and they followed this group of 628 people for 11 years to see if there was any association between their periodontal disease and the risk of dying from cardiovascular disease. And during that 11 years, basically a third of the people dropped dead. So that's a hard endpoint. You can't argue with death. And what they found was that if the person did not have periodontal disease or only had mild periodontal disease, none of those individuals perished for cardiorenal disease. But if they had severe periodontal disease, they had triple the risk of dropping dead from a cardiorenal death. And again, you can see the numerous adjustments they made. And that's important to realize they adjusted for all those other things, including the few that did smoke. That's Dr. Neighbors.
Just a comment here. For those of us who are observing patients with periodontal disease, in our training, sometimes we really are at a point in trying to determine if our patient has enough periodontal disease to actually go through treatment. I think this study is so critical for us to understand as providers and as screeners and as preventors of end-stage disease, that we have a great responsibility for our patients to determine if they have disease, if they don't have disease, to prevent disease, if they have mild disease, to treat mild disease. We can't wait, based on this study here, for our patients to end up with 6-millimeter pocketing. That's severe periodontal disease, and yet, as I look at clinical laboratory reports, literally hundreds of thousands of clinical laboratory reports, the average pocket depth that I see from clinicians is almost 6 millimeters. What does that mean? That means that we typically, in our practice, the real truth is that we are not checking, we are at least allowing some of our patients to get more severe than they need to get. And I think this study clearly shows that if we have the responsibility of preventing, that we have to intervene much earlier, and that's in the no or mild periodontal disease.
Yes, great point. And the other point I need to make with the studies, these were type 2 diabetics, so that's one reason a third of them dropped dead. And they obviously do have high risk mortality risk, and they carry extremely high risk of suffering a cardiorenal death. And it really is rather amazing that none of them suffered that type of death if they didn't have periodontal disease or if it was just mild. It's a remarkable study and published in a good journal, Diabetes Care. So moving on, so we've shown periodontal disease is associated with risk factors, development of the disease, and there are other studies showing it's associated with cardiovascular events. So then the logical question is, well, hey, does it make any difference if I treat it? Will I reduce the risk? Because if that's not the case, what are we talking about? So there is evidence, and we're just going to show one little piece of that tonight, and that deals again with type 2 diabetics. They looked at basically 370 diabetics who had periodontal disease, and about half of them they treated with scaling and root planing. Some got antibiotics, some didn't. The other half, they didn't get treated. And what they found was 3 to 9 months later, the ones that got treatment, they had a significant reduction in their average blood sugar levels as measured by the hemoglobin A1C. And we do know, obviously, there's an association between glycemic levels and risk of cardiovascular events and death. And there are lots of other studies that show treatment makes a difference with inflammatory markers, with endothelial function, and an excellent study that incorporated the use of doxycycline with periodontal disease showing significant reduction in cardiovascular risk.
Dr. Bale, I would like for you to make a comment on this previous slide, and that is the A1C change in treatment versus non-treatment groups of a 0.4%. For those of us that see this, we may think, well, gosh, that doesn't look like a big deal. Well, how does that correlate with medications that you would give to your patients when you are combating these types of serum changes?
Yeah, probably all I need to say is if you develop a drug and it can demonstrate that type of reduction in that period of time with the A1C, the FDA will approve it for diabetic use. Mm-hmm. So that's how powerful it is. Yes.
Yeah.
Good
That's
question.
a big deal. That's the point.
Right.
Yeah.
Yeah. Yeah. Thanks.
Yes.
Okay, so moving on again with the American Heart Association paper, again, they did show level A evidence of periodontal disease is independently associated with arterial disease. That's a big, big deal. And they also concluded that the evidence that we have that looks at treating periodontal disease does show a positive trend toward reducing that cardiovascular risk. That's a big deal as well. The thing that caused all the confusion was when they commented, well, the evidence we have doesn't show causality. We can't absolutely say that periodontal disease causes arterial disease. And that really should not be surprising for numerous reasons. Number one, you've got to get a definition that really fits. So if the definition of periodontal disease includes, bone loss and pocket depths as opposed to concentration of bacteria, it probably is going to be hard to show causality. The definition, again, probably at least needs to include that in the definition. And a lot of the studies that they look at, have various definitions of periodontal disease. There needs to be a universal definition, and it probably does need to include bacterial burden. So that's one issue. Another issue is the studies that they looked at to try and show causality. Various treatments were utilized for periodontal disease, and the endpoints in terms of showing, well, was the treatment effective or not, varied as well. So again, if you're going to design a study to show causality, you have to have treatment protocols that are known to be effective, and you have to have objective measurements that will demonstrate the effectiveness of the treatment. Another huge issue is there are numerous known risk factors for cardiovascular disease. So any study that's going to show causality has to have all of those other risk factors matched perfectly in the beginning at baseline between the group that's going to get periodontal treatment and the group that isn't. And guess what? At the end of the study, you have to show that they're still significantly similar. And if you can't do that, then somebody's going to argue, well, the blood pressure, it got better in the group that got treatment, so it was the blood pressure. So it's going to be extremely difficult to control all those confounding risk factors. I'm not saying it's impossible, but it's going to be extremely difficult. And then the last point a lot of people aren't even aware of, but there was an excellent publication within the last year that tells us most events, and by event I mean when you have disease in the wall of the artery and the surface above it, the inside lining of the artery either gets ruptured or eroded, and then you get the subsequent blood clot that blocks the flow of blood. Most of those events are not symptomatic. Most of them are silent. So any endpoints in the future to show causality are going to have to include incidents of heart failure, silent heart attacks, silent strokes, etc. It's going to be extremely difficult to do, but not impossible. But the bottom line is, in our opinion, causality is not a prerequisite for making the statement periodontal disease has to be included in any program dealing with cardiovascular prevention. Simply having level A evidence that it's independently associated with cardiovascular disease is more than adequate, along with their statement that the trend appears treatment of periodontal disease reduces risk. So there's no reason to wait for this causality study to start including periodontal disease and oral systemic connection in cardiovascular prevention programs. And then this next slide, maybe Tom, I'll let you or Danny talk about that, and Dr. Neighbors is going to kind of take over from this point.
Well, I just wonder if maybe it'd be a good time to summarize what you feel that the medical and dental teams need to know about periodontal disease, which might help them to develop or reassess, in the case of those that don't even have an opinion at this point, but their thoughts about this relationship. I guess you've been sharing a lot of that, but if you had to distill it down sort of as a checklist, or what really they need to look at, where would you start?
Good. The big picture is that we now have excellent evidence inflammation is causal of arterial disease, and the inflammation that causes arterial disease is simply a manifestation of numerous other potential pathologies, whether that be sleep apnea, whether it be horrible cholesterol, whether it be the insulin-resistant condition. One of those pathologies definitely is periodontal disease. Periodontal disease can crank up systemic inflammation to the point it drives the formation, the propagation, and can lead to an arterial event. So periodontal disease is extremely important, and any program that's claiming they're trying to prevent cardiovascular disease that doesn't address this is making a huge mistake. So I don't know, is that
very good.
Enough of a summary?
I think so.
I would like to just make a comment, from the dentists that are listening, as to certainly the significant part that Dr. Bale is stating, and I'm sure Ms. Doneen would say exactly the same thing or something very similar. They take periodontal disease very, very seriously because it is an independent risk factor for the diseases that they are trying to prevent in their patient base. So I would say to us as dentists that we need to take periodontal disease as seriously as they do. We tend to have in our profession segmented responsibilities, and we tend to place certain areas of responsibility to different staff members, and I would say that we need to get together as teams and determine that periodontal disease is going to be a primary focus of our practice. Doctors have to get engaged with their hygienists. Hygienists have to get engaged with their doctors. And then we have to get engaged with our patients about explaining the critical need for detecting periodontal disease. We certainly have to use the AAP parameters of care. We have to do probe charts. We have to look at medical histories. And we have to do all of those things that we know to do. But I would think the most important thing that we have to do is realize that this is a big deal, that we can have a part in preventing these life-threatening events, actually saving lives by detecting periodontal disease earlier and treating it effectively and having ways of measuring whether or not our end result is effective. And I oftentimes say in my presentation that procedures alone do not guarantee effectiveness. Dr. Bale may give us a medication for, let's say, hypertension, or another medication for, let's say, LDL cholesterol elevation, but he will monitor that to determine if the therapy is actually being effective. If it is effective, he'll continue that route. If it's ineffective, he'll change therapy, and we have to use that same kind of very, very dedicated model to making sure that we are engaged with these patients because it's a serious disease.
And
Yeah,
as dentists, we really have an opportunity to do that more than medical professionals because of the frequency
Yes.
that we're able to see patients.
Yes.
Yeah, just to give you a quick example, I do see patients from all over the country, and I've got a new patient that I'm engaged with now out of New Jersey who wants a thorough cardiovascular risk evaluation. I can't provide that without having this oral periodontal information. So fortunately, I found an oral medicine specialist in New Jersey whose practice isn't far from this individual, and he's already made an appointment to see him, and he's going to get the type of testing that I require in order to know about the potential for the oral disease driving his cardiovascular risk. So the medical providers need more oral medicine specialists in the country. So thanks again for being on the call. Appreciate it.
Absolutely. Indeed.
Well, this is a point where I will make some closing comments, and the statement that you see here is taken from a textbook called Periodontics, Medicine, Surgery, and Implants, published in 2004. I was using this slide a number of years ago, and it just I was reminded of myself in getting ready for this presentation that I stopped using it, but I've put it back into all of my presentations now because this is where we need to be. We need to realize, yes, we are trained to save teeth. We are trained very well to do surgery, to place implants, do restorative care, sleep apnea, and so forth. But as Dr. Bale was stating, the CDC statistics and others, periodontal disease is without a doubt the most prevalent chronic infection that we certainly deal with in the adult population. And this statement clearly says that along with our ability to save teeth and to restore function and aesthetics and beauty, that our greatest role as providers is not the saving of teeth, but is in fact our ability to detect infection accurately, our ability to control infection, and our ability as providers of health care to establish an oral environment that is conducive to the overall health and well-being of the patient. This statement makes perfect sense after hearing Dr. Bale's excellent presentation on our ability to look at periodontal disease as a risk indicator, as in fact an independent risk marker for those that have periodontal disease. There have been at least 5 studies since 2002 that have been published in the Journal of American Dental Association and other places that clearly say that we as dentists need to take a more proactive role in systemic health. So as we look at this information and as we go to this course, do not be alarmed that we are doing something out of the box that is not accepted by both the medical environment and, quote, the oral medical environment. In other words, physicians and dentists, medical institutions and hospitals and dental schools have come together to clearly say that dentists can be involved and should take a more proactive role in evaluating their patients' potential risk for systemic disease. This article was published actually in 1999 in the Journal of Medical Association, Journal of the American Medical Association. And it talks about the dentist and the impact that we may have in looking at vascular disease and diabetes. Our role is not to treat these diseases, but our role clearly can be as screeners, as educators, and monitors of risk factors. Our course will help us understand, along with our role as providing excellent oral health, how we can know the real keys of what it means to be a screener, what it means to be a good educator, and what it means to be a real excellent monitor of risk factors. So all of our teams, and we hope that you're bringing your teams with you, we will need to know. We need to know today how we can impact vascular disease and diabetes in our friends and our family and in our patients. I'm reminded after practicing for almost 40 years and then becoming very interested in molecular diagnostics and genetics, is that many of our patients stay with us for decades. We see them as they become aged, and we see them as they actually change in their health. And what we can say today is that we may have an ability to prevent some of these life-threatening events or even prevent death by knowing exactly what to do. And so we need to learn what is it in our medical history, and we will actually have an opportunity to look at a revised medical history. What about blood pressure? How important is that we do that on every one of our patients? What about oral health? What can we look at in oral health to determine risk for systemic disease? And what does it mean to look at risk factors? We'll know that. This particular article from the American Heart Association scientific session in November of last year said that if we look at the right things in the mouth, that we can predict with a 63% accuracy rate individuals that are at risk for heart attack. I want to be able to tell my patients that, my family members that, my wife that, and those that trust their health in my hands. Dr. Bale mentioned hypertension and pre-hypertension. You can go online. There's two studies, both published in September. One is the PURE trial that recently was published on a perspective of urban and rural epidemiological studies that was included 17 countries and 5 continents and over 170,000 individuals. And then in the CDC study that was published September 11th, and they both come out with the same conclusion, and that is in America that greater than 40% of the population is either pre-hypertensive or hypertensive, and approximately 50% of these are undiagnosed. What a wonderful opportunity that we have, because we see our patients at least every 6 months, sometimes every 3 months, or at the latest once a year. But by screening for pre-hypertension, the articles clearly state that we can prevent 46,000 deaths per year, and by using this team approach and being involved in this particular activity. From diabetes, we will learn at this course how we as dentists can, with a 73% accuracy rate, predict diabetes or prediabetes just by looking at factors in the mouth. And if we learn one simple test that involves serum, and we know what this means, if we know how to interpret that test, we can evaluate an accuracy rate of 92% of those that are diabetic or pre-diabetic. So we have a wonderful opportunity to do that. Some might ask, well, gosh, what will my patients think about that? Will it be good for my practice or not? Well, the studies are already there. And the bottom line is that patients' attitudes regarding their dentist that includes this kind of medical evaluation and screening and educating and monitoring of risk factors improves their practice. Patients see their dentist as a more holistic provider of health, and actually it is a very, very favorable thing. And the last slide that I show, and we'll discuss this in our course, is don't forget yourself. And that is that all of us have a lifetime risk of developing heart disease. If you're a male and you're 40 years old or older, your lifetime risk is almost 49% that you'll have a coronary event or you'll have some form of coronary heart disease. If you're a lady or woman, you have the lifetime risk of almost 32%. And then when you add risk factors, these factors simply add to greater risk. And one thing that you will also learn is that risk factors begin at a much younger age than we ever thought. So we will be looking at how we can work with physicians, how physicians can work with us, and how we can also help ascertain the overall health of our patients and who we should be referring to our colleagues that understand what we're doing and what we're trying to accomplish. So Dr. Bale, I'll turn this over to you as we finish.
Yeah, and I think we're used up our hours, so I'll go kind of quickly over the last few, but these take-home, you can just look at that, and we've already covered all that. So let's move on to the next slide, and that's what will you get if you come to this course in November that we're offering. Well, one thing, it certainly will enhance your ability to be known as an oral medicine specialist in your community. And Tom, I was just thinking I'll need to go over this with Amy as well, but it just occurred to me we should have a sign-up sheet for people that come to that course. If they want, we could post their name on our website where all the medical providers go to, so that they could learn, well, yeah, this person went to this course.
Great
so
idea.
that's an oral medicine specialist. As a medical provider, I'm going to at least want to investigate establishing a relationship with.
Great idea.
You're going to get
to a marketer's ears.
Yep.
Very important.
Yeah, no, I don't see why not. Obviously we have to have the permission of the people attending, but the people that attend this course should walk away with the tools they need to collaborate with the medical community in this arena in terms of testing, the history they take, and I would think it'd be a wonderful thing, because our medical providers are starving for more oral medicine specialists. I say, anybody who goes through a course realizes, yeah, if you're going to do a thorough assessment and evaluation and do your utmost to reduce somebody's cardiovascular risk, you have to incorporate the oral systemic connection, and that means you have to collaborate with an oral medicine specialist. So where are they? There are not a whole lot of them out there, but that's why we're doing the course.
That's right.
So anyway, we need to rewrite the American Heart Association impact goals for the current decade. They were very remiss when they failed to include oral health in their impact goals. That's extremely important, and I'm sure if we talk directly to the folks that were involved in establishing those goals, they would agree with us that that's a critical component. So again, I appreciate everybody's interest in this, and I hope I get to meet a lot of you in person in Las Vegas. It's going to be a lot of fun. We're going to have simulated visits with patients seeing the dental side, patients seeing the medical side. How do you communicate to the patient? How do the two professions communicate with themselves? And we're going to deliver forms that can be used, sample letters that can be used, marketing tools that can be used so that the word gets out in your community. So thanks for being part of this, and I think we do have time for questions.
We do indeed, and first allow me to thank Doctors Bale and Neighbors for not only an informative and enlightening presentation, but I think a very empowering one. I think the point that I hope is not lost on anyone is that you as oral health professionals are being offered the means to literally save the lives of your patients, to do so much more for them than traditional dentistry offers. And what that means for the relationship, the quality, the longevity of the relationship is inestimable. And we talk about improving patient outcomes while improving practice incomes, and it's a beautiful thing when those two are two sides of the same coin, as they are in this situation. The relationship will just be deepened. The one caveat or one qualifier I would say is that when you come back from this session, or perhaps even after this sneak peek of the session, and just imagine what the full day will bring, you want to be careful to not be like have the zealotry of the recent convert, so to speak, because people need to be given time to be brought up to speed. So your patients, likewise, you want to be measured in your communications, offer them choices, educate them slowly, And, you know, to overnight say we're now an oral systemic practice and we're going to save your lives by delivering all these protocols, you could understandably see where they might be like, wait a minute. But
Yeah.
so you want to be measured and thoughtful in your communications. And something that may seem simplistic, but it occurred to me while I was preparing for tonight's presentation that heart attacks and other such events, cardiovascular events, I think are more or less accepted as a fact of life by people, not the least of which are cardiologists, which is why I'm so grateful for Bale and Doneen and Dr. Neighbors and others that are leading the charge for prevention. But what we're talking about is not accepting heart attacks as well. That's natural causes. His time or her time came. That's not the case. It need not be the case, because what we can do is, if not prevent it from ever occurring, what we're talking about, I think, is preventing a premature occurrence, an unnecessary occurrence. And now that we've got these incontrovertible links, these causal factors that showed that smoking guns, if you will, I just think it's an exciting time to be a dentist, and I'm sure you all agree with that. We are going to also offer all attendees the opportunity to get 2 hours of continuing education credit through Penwell, and our colleague and friend Richard Nagelberg, who's in charge of their continuing education curriculum, will also be presenting along with Doug Thompson at your meeting in November, right, gentlemen?
Yes, we're
Right.
excited about that. Yes.
Yep, so we're excited about that too. Everyone who attends will receive an email from us with a link to take the written exam, and for $49 you will receive 2 hours of continuing education credit for having attended this program this evening. Now my better half, my life and business partner Virginia Norton, has been quietly waiting in the wings collecting questions and comments from attendees, and at this point I'd like to ask her to share some of those with us and give the doctors a chance to respond.
Okay, well, one of the first questions was, will there be some other seminar dates besides the one coming up on November 2nd?
That is our plan. We don't have dates set, Dr. Bale, but we certainly hope that this is going to be an ongoing process, and we would certainly appreciate your letting us know how interested you are, and the more that we have that are interested, of course, the more incentive we'll have to actually do this. And so we look forward to knowing who you are. Let us know if you want to have another date and when that would work for you, because we would love to do this on an ongoing basis.
Yeah, that's an excellent point, Dr. Neighbors, because we have put a lot of time and energy into putting this together, and obviously whether or not we do another one will depend on how successful the initial program is and what type of interest is out there. So excellent point.
Great, and people can visit baledoneen.com for more information, correct?
Correct.
Okay. Then we have a question here that says, do we have any statistics that compare cardiovascular disease rates in other countries, like Scandinavia, for example?
Yes, there are. You know, the United Nations, of course, just had a huge session dealing with cardiovascular disease on a worldwide basis, and it's estimated that it's going to cost the world, I believe they said over the next decade, like $44 trillion in preventable cardiovascular events and unnecessary deaths if more action isn't taken. All developing countries, the number one killer is cardiovascular disease. The number one disabler is stroke. Now, granted, cancer is not far behind, but cardiovascular disease is still number one. So the United Nations is very aware of it and just had a special session on that.
I might also add that if you will just Google the PURE trial, that's capital P-U-R-E, that was just published in September, included 17 European countries and 5 continents, of course, then which included the United States. And so as Dr. Bale was stating there, hypertension, prehypertension is as prevalent in the European countries as it is in the United States.
Yeah, and China is rapidly catching up.
Yeah.
Yeah. Okay.
Okay, we have one comment that somebody wanted to share, and they said, Dr. Restman also submitted a significant rebuttal of a columnist's comment on this issue in the RDH magazine, September 2012. So don't know if anyone else is familiar with that, but some
I do know Dr. Whitney.
Was the rebuttal on the relationship between vascular disease and periodontal disease? I'm not sure what the rebuttal is.
I believe that perhaps the statements that were made recently by the that you guys cited.
Yeah, I would state if anyone has a different opinion, we would encourage them to come because we would love to have the rebuttal on November the 2nd. Would you agree with that, Dr. Bale? Because I can clearly show you that we have the literature that will provide the evidence that of what we are showing is the science. This isn't our opinion. This is the science, and we would love for that individual and any others that may have a different opinion to come to this course.
So that was a rebuttal to the, that wasn't a opposing view to the AHA, it was supportive of the AHA's view?
It sounded to me like it was a rebuttal to the AHA viewpoint. So it's probably in support of.
It may have
been supportive. Yeah, okay.
I mean, actually, the AHA paper was absolutely fantastic. It's just the way the media spun it. That was what was bad. What they delivered was fantastic information, totally in support of what we've talked about tonight.
You know, it was perhaps an unfortunate choice of title, but then again, maybe it wouldn't have generated all the publicity, and maybe the people that wrote it and submitted it knew exactly what they were doing.
Yeah. Good point.
You never know.
Okay, and we have one final question, which is, will you address systemic inoculation as a function of oral prophylaxis, subgin scaling without first determining what pathogenic microbacterial environment exists, especially on pre-hypertensive patients, pre-diabetic patients, etc.?
Yeah, Dr. Neighbors, you want to take that?
Well, if I understand the question, the individual is asking what should we do with individuals that have periodontal disease that also have already suffered an event. Is that basically the question? Or who is at risk for an event?
Well, I'll read it again just so maybe we can absorb it a little bit better because it's a little confusing. Will you address systemic inoculation as a function of oral prophylaxis, subgin scaling without first determining what pathogenic microbacterial environment exists?
So is this a case-by-case basis?
Yeah.
It sounds like.
Sure. Well, I would also say that we do have studies, and let me address this rather indirectly and then more directly. The question is a very good one, and the question is, we don't have a complete answer to that, but we do have studies that clearly show that invasive dental procedures such as dental extractions, placing of implants, and periodontal treatment do in fact increase risk for cardiovascular events, including heart attack and stroke. And we do have an excellent study that has evaluated several hundred people and have followed them after the invasive procedures. And it is somewhat alarming to see the incidence of heart attacks and strokes after invasive dental procedures. And if the author of the question is asking, can we do better, and I think the answer is yes, we can do better. And one of the things that we will be discussing at our meeting is, you know, when should we be treating patients that are at risk or who are infected, and how will the medical history change what we do? And we address that with the question or the answer, and that is, you know, when is the most appropriate time to treat an individual that is at high risk based on all of the factors that we will be looking at? It's a great question, and we will address that more at the particular meeting that we have on November 2nd.
Yeah, Dr. Neighbors makes an excellent point. At our course, we will be discussing inexpensive, very simple urine and blood tests that can let us know if the patient is high risk at the moment. What triggers an event is inflammation, and certainly if those tests are done, and it indicates the patient is extremely hot, so to speak, at the moment. They're very inflamed, that they could have an event any moment. That would be a patient we'd want to work on to cool them off first before you got very aggressive with the periodontal treatment.
Very interesting. Well, gentlemen, thank you very much once more. I'm looking forward to seeing you in November. This is one of the high points of my year. I can't wait to attend and soak it all up. It's going to be fantastic. And I look forward to seeing all of you attendees at this very special event as well. I'm sure that you'll be glad and will consider time very well spent. And after all, it is in Las Vegas, and you'll have the weekend afterwards to, to review your notes, of course.
Right.
And our next Practice Perfection webinar will be on October 25th, and the title of that is Abracadabra, where our special guest will be Mary Ann Harper, whose specialty is effective use of medical and dental cross-coding to ensure timely treatment reimbursement. Again, very consistent with the oral systemic practice and to help grow the practice. This is obviously an important component of it. In the meantime, thank you everyone again for your time this evening, for attending what I hope you agree was a very enlightening and empowering event. And Drs. Bale and Neighbors, thank you very much. And until next time, I'm Danny Bobrow, and thank you very much for your time.
Thank you.
Thank you. Okay, bye.